η οποία θα δοθεί από τον καθηγητή κύριο Walsh. Νομίζω αρκετοί από εμάς τον γνωρίζουμε. Είναι καθηγητής παθολογίας, λοιμοξιολογίας στο Κορνέλ στη Νέα Υόρκη. Νομίζω για όσους δεν γνωρίζουμε, το βιογραφικό του είναι, θα έλεγα, φοβερό. Έχει κάνει ειδικότητα στη παθολογική ανατομική, πλήρη ειδικότητα, board certified, στη παθολογία, στη λοιμοξιολογία και ενηλίκων και παιδιών και τελευταία και στη μυκητολογία, η τελευταία του εξειδίκευση. Είναι παγκοσμίως γνωστός σαν γκουρού των λοιμόξεων και κυρίως των μυκητιάσεων, πάνω από 800 τόσες δημοσιεύσεις, πάνω από 20.000 τόσες αμέτρητες αναφορές στις δημοσιεύσεις του. Σαφώς έχει πάρα πολύ μεγάλη αγάπη για την Ελλάδα. Ήδη κάθε τόσο έρχεται στην Ελλάδα και μάλιστα έχει στήσει και ερευνητικά προγράμματα και εδώ, αλλά και έχουμε στήσει μαζί, αλλά και στην Αθήνα προσφάτως, στην Ακαδημία Αθηνών, στο κέντρο της Ακαδημίας Αθηνών, με πειραματόζωα εκεί πέρα, οπότε και με συνεργάτες από την Αθήνα. Νομίζω ότι είναι άνθρωπος ο οποίος σαφώς μπορεί να θεωρήσουμε ότι και μας αγαπάει πάρα πολύ, αλλά και εμείς τον εκτιμούμε πάρα πολύ, και το θέμα που θα μας αναλύσει σήμερα είναι πολυανθεκτικοί οργανισμοί στην κοινότητα και στους χώρους παροχής υπηρεσιών υγείας, η νέα παγκόσμια απειλή. Μην ξεχνάμε ότι μαζί με τα υπόλοιπα, τα διάφορα θέματα που ακούσαμε, και οι πολυανθεκτικοί μικροοργανισμοί, είτε αυτοί είναι βακτήρια, είτε είναι άλλοι μικροοργανισμοί, μύκητες, είναι μια πάρα πολύ μεγάλη απειλή παγκόσμια. Και βέβαια έχει χαρακτηριστεί και από τον Κόσμο Οργανισμό Υγείας σαν μία από τις 2-3 μεγάλες απειλές. Tom, I think you understood some of my introduction, so no more.
Well, Caro sabato Kyriako. It is I want to thank Dr. Voroilides and the other members of the organizing committee for the kind invitation to be able to visit Thessaloniki again and to participate in this outstanding conference. In the limited time that we have, I'm going to address the multi-drug resistant organisms, but I will focus specifically on gram-negative infections. We can discuss and question and answer the broader aspect of gram-positives, but for the sophisticated nature of this audience, we will focus specifically on the multi-drug resistant gram-negatives. So, to begin, we have seen, let's see, I can advance. We have seen the global emergence of gram-negative bacterial pathogens in communities and in hospitals. There is a strong epidemiologic predominance of gram-negative pathogens, especially in our immunocompromised patients, especially in neutropenic patients, the population that will, in your institutions, be extremely vulnerable to these devastating infections. We see emerging common gram-negative pathogens that we know and that we know well become multi-drug resistant. What are these pathogens? Escherichia coli, Klebsiella species, especially Klebsiella pneumoniae, Pseudomonas aeruginosa, Stenotrophomonas multifilia, Enterobacter, Citrobacter, and Acinetobacter. Well, if we look at the standards for single-agent therapy, we commonly use anti-pseudomonal cephalosporins for suspected gram-negative sepsis, such as ceftazidime or cefepime. We may use an anti-pseudomonal penicillin, such as piperacillin or tazobactam. Commonly, we will use for suspected resistant organisms carbapenems, meropenem, or imipenem cilistatin. But understanding local unit-based antimicrobial spectrum is critical in this decision. The decision that you may make in a small community hospital with relatively few resistant organisms may be very different from that in a complicated, large tertiary care institution. For units with relatively few resistant gram-negatives, we tend to employ a single agent, anti-pseudomonal beta-lactam or carbapenem antimicrobial therapy for suspected gram-negative sepsis. But for units in institutions that have high-level resistant gram-negative infections, we are forced to use combination therapy, such as an anti-pseudomonal beta-lactam or carbapenem antimicrobial therapy plus an aminoglycoside to provide the broad initial coverage of multi-drug resistant organism. And though our children may tolerate aminoglycoside well for the initial therapy, so patients such as neutropenic patients, patients with cystic fibrosis, who may see repeated cycles of aminoglycoside therapy, do suffer the consequences, particularly for eighth nerve injury and for cumulative renal impairment. If the organism is later found to be susceptible to an anti-pseudomonal beta-lactam or carbapenem, then we would be employing an aminoglycoside or fluoroquinolone. But as we encounter more and more resistant organisms, we then have to understand what is the basic molecular foundation for these organisms. We see extended spectrum beta-lactamase now largely encoded on plasmids with E. coli and Klebsiella species. We see the emergence of carbapenemase producers, most commonly beta-lactamase producing KPCs, such as in E. coli also and Klebsiella. But bear in mind that carbapenemase producers may also be caused by NDM1, New Delhi metallo-beta-lactamase inhibitors. Though uncommon, they still remain a very important threat. But by far and away, the beta-lactamase KPC remains a much wider global threat across institutions and throughout countries. With Pseudomonas aeruginosa, it is as if the organism had read a textbook on multi-drug resistance. It elaborates facilitated diffusion, efflux pumps. It is able to downregulate or mutate porins. It elaborates an enormous host of beta-lactamase, for example, Vim metallo-beta-lactamases. All of these pose considerable difficulty in trying to identify a single agent. A mutation in a poron, for example, such as an OPRD, may completely suppress the ability to be able to deliver all beta-lactams and carbapenems. The increasing propagation of facilitated or diffusion in efflux pumps makes any effort to sustain high concentrations, such as with continuous infusion, even more difficult. If that was not enough, we then encounter, even with the success of anti-pseudomonal therapy, the emergence of Stenotrophomonas multifilia. In many institutions, Stenotrophomonas multifilia may constitute even more of a threat, more commonly, than that of Pseudomonas aeruginosa. The organism is especially challenging because not only does it have the metallo-beta-lactamase associated with the L1 gene, but with L2 it has also a serine beta-lactamase which requires a second coverage. Once the organism becomes resistant to trimethoprim sulfamethoxazole, there are very few, if any, therapeutic options. Emergence of resistance occurs rapidly to fluoroquinolone and to ticarcillin timentin. And thus, many institutions now see the emergence of Stenotrophomonas multifilia in the wake of Pseudomonas aeruginosa. This especially becomes problematic when institutions are using, in a hospitalized setting, or immunocompromised patients with impaired cell-mediated immunity, trimethoprim sulfamethoxazole for anti-pneumocystis therapy. The organisms that are trending now for Stenotrophomonas are now fully resistant to trimethoprim sulfa, thereby offering virtually nothing for these multi-drug resistant pathogens. Increasingly, we see the persistence in institution of stably de-repressed beta-lactamase producers, AMP-C, often driven by cephalosporins. And with our new advances that we have seen, which I'll mention to you, of new generation cephalosporins, these organisms pose a threat to reemergence, even as we overcome ESBL and KPC. The Enterobacter, Citrobacter species, as well as Providencia and Morganella, and represent still threats that dominated in the 1990s, and the concern is they may reemerge under the cephalosporin pressure. Especially challenging now from a molecular and epidemiological standpoint is Acinetobacter. Acinetobacter employs a very different set of systems for emergence of resistance. It entails an entire, what we refer to as an integron, which is a massive cassette, often as much as 1 to 2 megabases of resistant genes that can be simultaneously all upregulated, with simultaneous emergence of resistance for beta-lactams, carbapenems, fluoroquinolones, aminoglycosides, and agents such as tigecycline. The organism is able to acquire these genes from a number of different sources and in a coordinated manner in a chromosomal cassette be able to simultaneously upregulate these. Its persistence in the aqueous environment, particularly in burn units and neonatal units, in intensive care units, is notorious. It survives relatively well environmentally, and patients can easily be transferred from chronic care facilities into one's institution, even if one did not have Acinetobacter. But once established, particularly in waterborne environments, then the organism is extremely difficult to eradicate. So what is the problem of globally, if we were to look at specific examples? One of the new emerging threats that continues to challenge our use of carbapenems as a salvage therapy, particularly for those with patients with ESBL, is the emergence of carbapenemase resistance. This originated from the earlier studies with carbapenemase producers in New York City and Israel, almost simultaneously. 21%, for example, of Klebsiella pneumonia isolates reported to the Centers for Disease Control and Prevention in 2006 and 2007 were carbapenemase resistant. Now, if we look nationally in the United States and we look globally, more than 30, since the 2006-2007 outbreak, more than 35 states in the United States and an estimated now 30 countries, and the number continues to increase, are reporting the carbapenemase resistant, hence reflecting the ability for these organisms to propagate globally as patients and organisms and other sources are transmitted through rapid transportation systems. So carbapenemase resistance, for example, in the United States is most commonly caused by KPC, but bear in mind that we also have the threat of New Delhi metallo-beta-lactamase production. That has not transmitted as rapidly as was feared. Instead, KPC, as a molecular entity, has been transmitted globally at a very rapid rate. Now, if we think for a moment of New Delhi metallo-beta-lactamase production, we realize that this was reported as a local clone that, from the paper of Mata et al., was a local clone with worldwide global aspirations. These clones of CRE historically resided in hospitals or long-term care facilities, but by contrast, with NDM1, particularly being identified in the sewage, for example, they have now the capability of thriving in the community and quickly spreading across countries and continents in relationship to accessible, rapid global travel. A common source being identified almost universally across countries within specific institutions, allowing the community development within the institution of the organism to propagate, is the profligate extensive antimicrobial use. It becomes apparent that wise antimicrobial stewardship and effective infection control measures in a number of institutions now have been able to control carbapenemase resistance. But the organism still remains a threat, but just the converse of it, the indiscriminate use of antimicrobials and poor infection control practices are a recipe potentially for propagating these organisms once they're introduced. So a local problem of resistance, seen as typified by New Delhi metallo-beta-lactamase, can rapidly become a potential global worldwide health crisis. If we want to explore more in more depth, we then ask ourselves in our own institution and in collaboration with other institutions, what is the impact in our most vulnerable patients, in pediatric and adult patients? What becomes the impact of carbapenemase resistant in a vulnerable population? And for that, in our own studies, we explored the possibility of hematological malignancies. And the reason why we examine hematological malignancies is that the expansion of these multi-drug resistant organisms in these very vulnerable populations have ominous implications. We know that Enterobacteriaceae are the most common cause of gram-negative bloodstream infections in the patients with hematological malignancies worldwide. The recommended antimicrobial agents for the management of fever in these patients do not have activity against carbapenemase resistance, with the ominous potential that we are initiating therapy for patients with suspected gram-negative sepsis that have no activity potentially against these multi-drug resistant organisms. And in the absence of neutrophils or in severely compromised hosts, the results we hypothesized would be catastrophic. We therefore studied the emergence of carbapenemase resistance in patients with hematological malignancies in a large oncology stem cell transplant center located in an endemic area. And this was specifically in the greater New York City area in the New York Presbyterian Hospital. In there, we identified 18 patients with malignancies, hematological malignancies that developed carbapenemase-resistant bloodstream infections. Well, 13, that is 72%, were neutropenic at the onset of bloodstream infection. And the initial empirical therapy was, unfortunately, despite following standard guidelines, European and Infectious Disease Society of America guidelines, the initial antimicrobial therapy was active in vitro only against 2 patients. Of course, we do not know the specific susceptibility. We know that patients are febrile, patients appear septic, that they can have potentially multi-drug resistant organisms, but most likely they're going to be susceptible. So we initiate standard therapy from ceftazidime, cefepime, carbapenems, or piperacillin tazobactam. A median of 55 hours elapsed between culture collection and receipt of an active agent. 10 patients, 56%, died during hospitalization, and all deaths were carbapenemase-resistant Enterobacteriaceae. So reflecting on this, if your institution does have carbapenemase-resistant organisms and you are using standard advanced therapy, in whether it's in a small or larger institution, the potential of being wrong carries ominous and catastrophic consequences for patients. So in this situation, the distribution was predominantly driven by Klebsiella pneumonia, but notably Enterobacter still is able to harbor block KPC, the beta-lactamase KPC, and then of course one can also see a polymicrobial. Occasionally we may also see Escherichia coli harboring the block KPC gene. One can see in a wide variety of hematological malignancies, leukemia, lymphoma, allogeneic stem cell transplant. So once the organism is established in an institution, it can propagate across different populations and indeed the most vulnerable populations. If we look at the mortality rates, they're striking, bearing in mind that for most patients with fever and neutropenia, with hematological malignancies, the overall survival is 95% from an episode of fever and neutropenia, and that's in the most advanced states. In many situations, we see survival from fever and neutropenia in all the randomized trials of as much as 98%. So this is usually a very treatable entity because of the advances that we've made both in antimicrobial therapy and clinical trials. We are losing that advantage to now we are able to see, for example, with 7-day mortality 39%, 14-day mortality 53%, inpatient overall 56%, inpatient if you're neutropenic nearly 70%. And if we look at the phenotypic characteristics, we may say, well, we can use other antimicrobials. Unfortunately, that is unlikely to be beneficial. If we do use polymyxin, while 80% are susceptible, we know that single-agent polymyxin or colistin from earlier studies during neutropenia and gram-negative sepsis carries a mortality rate of approximately 70%. So it may not help us. It's not highly bactericidal. We know that tigecycline is largely static, and the current data would indicate that as a single agent, it has relatively minimal activity against multi-drug resistant gram-negative infections, suggesting the need because of the emergence of resistance. Now, aminoglycosides are helpful, but used alone, obviously they carry, again, a high mortality. So one is therefore looking at the need for combination therapy. And then one loses, obviously, levofloxacin, trimethoprim sulfa. And why? There is no crossover of the mechanism, but instead the same organisms carry on the same plasmid genes that are encoding for example, fluoroquinolone resistance. The QNR gene, for example, encoding for resistance to fluoroquinolone often accompanies the resistant gene encoding for block KPC. Is there hope on the horizon? Yes. Globally, we can offer patients new potential antimicrobial agents. This has been difficult. As you know full well, many pharmaceutical companies have withdrawn from developing antimicrobial agents for a variety of reasons that could be discussed. But suffice it to say, there are those who have remained tenacious and committed to our patients. And in that regard, we do have, for example, the development of ceftazidime tazobactam. This agent will be especially helpful against multi-drug resistant Pseudomonas aeruginosa. Remember I mentioned the porin defects to you. It will bypass those porin defects. The tazobactam provides additional stability, but the novel approach is the ceftazidime. Avibactam, NXL104, when coupled with ceftazidime or ceftaroline, allows for very, very active impact on and microbicidal activity against carbapenemase-resistant Enterobacteriaceae. With potent inhibition of the block KPC, ceftazidime is protected and is able to confer the same level of antimicrobial activity as if it was susceptible Klebsiella pneumoniae. There are other entities that are not as fully developed, MK7655, and other key target enzymes for which there are antimicrobials, but for which there are still in vitro studies being conducted. But none of these combinations of note are active against metallo-beta-lactamases. The NDM1 is an example. Stenotrophomonas, again, which many of you have in your own institutions, we have no active agents. So the metallo-beta-lactamases remain a major challenge. We can only anticipate that as we continue to make advances against block KPC, as we continue to make advances against carbapenemase-resistant Enterobacteriaceae, that the metallo-beta-lactamases will fill a void, will fill a vacuum, and unfortunately still pose challenges, particularly in the hospital setting. There are other investigational agents, even more farther removed, but ones for which we hope there will be clinical trials, and these include a neoteric polymyxin, bisindol antimicrobials, LPXC inhibitors, and then boron-containing proton synthesis inhibitors. Of note, however, for the boron-containing molecules, there has been recent data to indicate the rapid emergence of resistance. So the data still remains uncertain about their future potential. So in summary, we know that resistant gram-negative infections are emerging factors for severe morbidity and mortality. They represent an expanding regional and global threat. They have expanded into immunocompromised hosts with cancer and stem cell transplant, and there is indeed a critical public health need for improved detection of multi-drug resistant gram-negative colonization and infection, improved effective preventative measures, and development of novel antimicrobial agents. And I would say Seferisto Parapoli for the honor of talking with you.
Thank you very much, Tom, for this excellent overview of the multi-resistant gram-negative bacteria. I think the topic is difficult, of course. Έχουμε τέτοια δυστυχώς πολλά μικρόβια στα νοσοκομεία μας. Ίσως σε άλλα νοσοκομεία μικρότερα λιγότερα, σε άλλα περισσότερα. Εάν κάποιος θέλει να ρωτήσει κάτι, I can ask you, Tom, we do have several ESBL gram-negative bacteria, and when we have a bacterial sepsis, in a department that it has a lot of ESBL bacteria, do you think that anything else than carbapenem is okay, like a combination of beta-lactam plus a beta-lactamase inhibitor, if it is, of course, in vitro active, or quinolone?
So
we do have neonates, or do we have immunocompromised patients, oncological patients that they do have several times ESBL bacteria?
So the ESBL is a very severe challenge, Emmanuel, because at the one hand, we want to preserve our carbapenem, but at the same time, we need to treat that particular patient. I think what may help guide intervention a priori may be knowing the susceptibility profile. So if you have a patient with resistant gram-negative, with them who is septic, there are several options. One may be realizing that you do not have the information initially. One could start the carbapenem, but then have hopefully rapid turnaround of susceptibility, and then try to change it, try to see where there may be the ability to have a sparing effect. Sometimes the ESBL is not a very high level of does not have a high level of resistance, and it may be possible to use continuous infusion of a beta-lactam if you can get above the MIC. We have been able to do that with ceftazidime, sometimes with piperacillin tazobactam, but the other and coupled with aminoglycoside or fluoroquinolone. And that, again, assumes a certain level of susceptibility. But certainly in a setting where there's high-level ESBL, particularly in a given unit, then probably the initial intervention with carbapenem is important.
Okay. Thank you very much for your talk. Νομίζω εδώ μπορούμε να σταματήσουμε.